maybe a few more questions are in order. You can ask some more questions. Core symptoms of depression, S-A-L-S-A, salsa. Now, you may know it as a dance. I know it as a spicy condiment that's put on tortillas where I come from. But let's ask a few more questions. Have you experienced any of these nearly every day for the past 2 weeks? Sleep disturbance, anhedonia, low self-esteem, appetite decrease. And 2 or more core symptoms really mean there needs to be more probing, more looking, more consideration of the presence of a major depression. Now, in the States, the psychologists tell me there's an epidemic of depression. People are they're very depressed. And we do know that depressed people are major consumers of health care. They will visit the doctor over and over. Plus, there's always the possibility of self-annihilation. So it's really serious and needs to be looked at. Remember, the depressed patient will come in worried, joint pain, headaches, tearfulness, and anger. Depressed men become very angry, often with little apparent cause, and brooding and anxiety. So these can all be clues to us to look for this. Now, there's big overlap. Depression overlaps with chronic soft tissue pain. At least a third of patients with rheumatoid arthritis are depressed, even osteoarthritis. So depression is associated with increased pain levels in arthritis, and it's more prevalent with the loss of valued activities. So remember, the 2 are interrelated. Can't separate one from the other. I want to talk just briefly about the somatoform pain disorders. There's a whole array of them. There's a list of diagnoses. I think it occurs it may be very serious, or it may just be that the patient is really concentrating on perceived pain. Very common in the primary care setting. Chronic pain, it cannot be explained by a known general medical condition, although sometimes these patients wish that you would make a diagnosis on them. Please. You can't. The symptoms cause significant distress. Their activities are impaired. They can get better, but it takes a lot of doctor-patient closeness, confidence. Cognitive behavioral treatment is useful, and psychiatric help may help them understand and deal with what they have. Now, how are we going to separate somatoform pain disorder from depression and everything else? Well, I typed in screening for somatoform disorder on Google, and I found a number of really easily self-administered tests that the patient can take these tests herself. Now, I'm going to rely on our colleagues in this organization to do a translation if it's needed. Okay, I don't have the translation. But if you can ask the patient or have her fill out the questionnaire to show that in the past 4 weeks she has had 3 or more of these symptoms, strongly consider somatoform disorder. And this was actually free on the internet from the American Family Physician. It's a journal published by the American Academy of Family Physicians. Now, I did take the test myself. I've chosen not to give you the results for me. I did go over it this morning. Okay. Well, let's treat our lady with fibromyalgia. Let's get her some help. First of all, we've reassured her that she does not have a serious disease. Now, the question that's hiding in many of these patients is, do I have cancer? At least that's what I see. So, no, we don't find evidence of cancer. You do not have a crippling disease. Your pain is real. Okay? Now, let's look at these treatments. Now, you can use all of these items, but which is the most important? I'm going to really emphasize one. You say go back to work tomorrow? She's probably able to, but she's not going to do it unless you intervene. See? I believe you got the right answer. Okay, so the most important, although not the only initial treatment, is conditioning exercises. Exercise, to walk, to go to a gym if there is one in your town, to increase function in spite of pain. Here the patient is moving and walking through pain. No steroids, no narcotics. Don't do it. Don't do it to your patient. Don't do it to yourself. Okay, now treatment is you want to keep the patient functional. You're reassuring her. You're educating her. If she has depression, you're treating it aggressively. She needs to stay in bed for 8 hours at night, even though she's not sleeping all the time. She should have her social interactions and the conditioning exercise program. Okay? So now I want to talk a little about pharmacologic options that may be added to this multifactorial treatment reassurance. Amitriptyline has been shown to be effective. It's usually given at very low doses, 10, 25 milligrams at bedtime. In the States, the FDA has approved 3 drugs for fibromyalgia. One is primarily an anticonvulsant that is also used for neurotherapy.